Yeah.
Right. So the right ventricle starts to fail. The patient starts getting palpitations, arrhythmias, syncope or fainting, and so on. And then doing an echo. The echo sometimes is difficult. A CT or MRI will show the relapse.
Yeah.
But on the long run, correction of TGA or TGA is very difficult. And usually they wouldn't do the surgery because they have to switch the atria and the great vessel.
And as you are mentioning that it's easy to diagnose on CT, but how to differentiate the LV from the RV on the wall?
Yeah.
When it is like 30 years, they will.
Yeah, that's very good. So there are some markers that would tell you where is the right ventricle and where is the left ventricle. Maybe I have lied on you. Why is this one is the right ventricle? Why?
Moderator band.
Very good, that's one. So the right ventricle has the moderator band, the left ventricle doesn't.
Tubiculations.
Tubiculations is more on the right side, on the left side, and the tricuspid valve.
Yeah.
So what the tricuspid valve is the most solid, to be honest, it's the solid point where you would say that this is the right ventricle, this is the left ventricle. And why? I'm not sure how could I make it larger, but in a normal subject, there is the septal attachment of the tricuspid valve, and on the other side of the septum, there is the attachment of the anterior mitral leaflet. The tricuspid is usually more apical, or almost always more apical, and the anterior mitral almost always toward the base. So there is a distance in between. And if you remember that, if this distance increases, there's an edge time, right? But there is a distance which is below 12 millimeter between the septal tricuspid and the anterior mitral. And the good thing is that as soon as you identify the tricuspid, this is the right ventricle. Yeah. So the tricuspid always moves with the right ventricle, and the mitral always moves with the left ventricle. So as soon as you identify the tricuspid, you could point out this the right ventricle.
Yeah, but as you mentioned earlier, we can diagnose it from axial when we see that the aorta is anterior to the pulmonary. So we may not
again, there are many complex forms of TGA. So there is TGA with the door with double outlets. So there are more complex forms. Yeah. And then sometimes you would fail to identify the three markers. So sometimes you wouldn't be able to see where is the right ventricle, where is the left ventricle.
Okay.
And it's not important anymore. It's what's important now is to identify the hemodynamic. How is blood is going? How would they correct it? Anatomical and hemodynamic.
Yeah.
But in many cases, those three indicators would help you to point out this is the right ventricle and this is the left ventricle.
Yeah. Okay.
So at any time, could you see, maybe you would be able to see it. So this attachment is more apical than this one, right?
Yeah.
So we could see a distance here. Right?
So that's tricuspid.
So that's the tricuspid, and this is the right ventricle.
Yeah.
Yeah.
What's the number again? 12.
I think it's 12.
Otherwise, I think biopsy.
And Epstein, yeah. And there is, of course, a spectrum of Epstein.
Yeah.
So there is Epsteinoid, which is Epstein-like, and then there is definite Epstein.
Mm-hmm. Okay.
Okay. So we went through the hemodynamic of the QPQS of those patients, how they look like, right? So now let's move to the surgical corrections, starting with the DTGA. So there are two surgery, or there are two options of correcting those DTGA. One is, and now I think that has been recently introduced, and most of the centers are doing it, that they would switch the arteries.
Yeah.
Because it was basically congenital anomaly, was that the arteries were switched, right? We said that the anomaly is ventricular arterial anatomical relation, right?
Yeah.
So they will switch the arteries. So they will switch, they will disconnect the coronaries, disconnect the aorta, and disconnect the pulmonaries, and then they just switch the arteries, and then they would reconnect the coronary.
Yeah.
From this surgery, what complication would you expect to happen? Because basically this is going to be you will be post-repair or in ACHD, is going to be the main clinical question that you will get in a CT or an MRI in those patients. what would you expect? So they disconnected the coronaries, disconnected the aorta and pulmonary, and then they reconnected the coronaries. So one of the complications would be stenosis, osteoarthritis, although it's very rare, but it's one of the concerns that could happen. Suturing the ostia, suturing those coronary buttons, something could happen. Or something could have happened during the surgery led to a myocardial infarction.
Oh, yeah.
Right. So this one, the ostia or the coronary, could we see it on MRI? Yes. And in most of the cases, it's successful to see it on MRI, whether the coronary, at least the proximal coronaries, because usually they are very young patients, you would not expect a coronary artery disease atherosclerosis or not. But the main concern is about osteal stenosis, it happened or not. So we could see it in MRI. If not, you could suggest, of course, a CT.
Yeah.
What else?
Leakage. If there is a failure of the procedure, like if there is leak or
Yeah, dehiscence and sutural,
yes,
more or less like any surgery, that's true. But again, what else? So there is a window. If they didn't do the surgery, the arterial switch within the first 2 or 3 months of life, then they cannot do it. And why is that? Because during the fetal life, the left ventricle was facing the pulmonary artery, right?
Yeah.
Before correction.
Yeah.
So the left ventricle had been facing a very low pressure, right?
Yeah.
So why should it develop? Why should it hypertrophy?
Oh, yeah.
Right? It's taking the place of the right ventricle, so it's very thin.
Yeah.
So in the first 2 or 3 months, then there is the possibility that if they do the switch, this left ventricle will hypertrophy and develop. But if they waited for a longer time, this left ventricle all of a sudden will see a high pressure of 120 to 80, then it will fail acutely. Because it's not hypertrophic.
Yeah.
And it's not trained to see this high pressure.
Mm.
So there is only a window of 2 or 3 months. Otherwise, they will go to the other surgery, which we will discuss now shortly.
Yeah.
So there is only a window of 2 or 3 months. So if they did the arterial switch, sometimes the left ventricle is not well hypertrophied, even if they do it in the first 2 or 3 months. So following up the left ventricle in the arterial switch is very important.
So I just would ask you said in the first part of this lecture that this is incompatible with life. How this patient are surviving for 3 or 4 months when all of the right side of blood is going to the systemic. So it's
very good.
All the systemic questions are ASD or BSD or
yes.
Oh yeah.
So it's a kind of a mercy, right? So they had this TGA, and in 90% of the cases, either there is an ASD or a BSD or a PDA.
Oh yeah. Yeah. Okay.
And if there is a PDA, then they would give the patient some prostaglandins to keep it open.
Okay.
Yeah. In very small number of cases, is that they are born without ASD, without BSD, without a PDA. Then on the spot, the pediatrician would do, by the echo, would do an ASD. So
yeah.
Otherwise, the patient will die.
Okay. Yeah.
Because there is no oxygenated blood.
Yeah. So it's something that's done at birth.
Yeah.
Okay.
Yeah. And it's, of course, that's why a pediatrician is always at day one checking the baby.
Yeah. That's very interesting.
You sometimes get really good if the size of the PA and the size of the aorta are not similar, and then they suture one to the other.
I don't think that the discrepancy would be that much, but sometimes regurgitation, stenosis, to be honest,
because it would be small.
of the surgeries,
Okay.
especially on the pulmonary side, because the type that's what I was going to say, the technique of the surgery, there is no space for the pulmonary arteries because they are reconstructing the switch. So they have to create this. I'm not sure if any of you saw this picture before, or did you see it in any of the TGAs, where you would find that the RPA and the LP are hugging the aorta, because this is the only space that they would, or to reconstruct the pulmonary vein. And this is how one of the complications is stenosis in the pulmonary and in the branch pulmonary as well.
Yeah.
This is, so if you see this axial cut, then probably this is called Lecomte maneuver. the French surgeon who did it. So this is the aorta, main pulmonary artery, right and left pulmonary arteries hugging the aorta.